He led the development of Rhode Island's cost growth benchmark program called Health Spending Accountability. Implemented the OHIC Data Hub and led the first comprehensive analysis of publicly funded health and social human service provider reimbursement rates. So welcome. Dr. Wayne Altman, an old friend, the Jahar's family chair and professor of family medicine at Tufts University School of Medicine, and the founder of the Massachusetts Primary Care Alliance for Patients. Welcome. Dr. Renee Crichlow, Chief Medical Officer of the Codman Square Health Center, a national leader in health equity and primary care workforce. Welcome. And Zai Kamsarvoravam, the former mayor of Newport and chair of Rhode Island Governor's Workforce Board. Welcome. And then Dr. Zirui Song, the Associate Professor for Healthcare Policy and Medicine at the Harvard Medical School and a primary care physician at Mass General Hospital, whose research and focus on payment reform, affordability, and the economic effects of healthcare policy. And together they're going to help us think about what it will take to finance primary care in a way that actually matches its public value. So please welcome the panel.
Okay, so we're going to level set so that everyone can where it is. Oh, there it is. Little comic relief. Not much to do. Boom. All right. So, thank you guys for coming, and thank you for changing primary care for the better. I promised all the students that I teach that we would fix it before they finish medical school. We got 3 years. We're in. One of the things that we're looking to do is, considering the fact that primary care provides value to the entire society, entire community, let's start thinking of it more as a public utility. These slides, well, that was awesome. Right. So you guys know that's all happening. We have what's called a free rider trap, where one of the reasons why we hear that insurance companies don't want to invest in primary care is that the payoff is long term, and that person's not going to be on their rolls next year. So that's a real issue for them. So one of the things that we learned about was there's this gentleman in Tokyo who ran basically the retirement pension account for the Japanese government, and he had a massive, like $1.4 trillion portfolio that he managed, and he realized, you know what, me investing in this company or that company or this company and that company, that's not really going to be helpful for us. We need to raise the entire level of the economy so that we can all thrive. He realized that treating it more of an umbrella where you have the idea that every single part of this economy can be improved. So they invested in many different things that actually pushed different companies to change their industry and improve overall. So this is what we call more of a universal solution, a universal owner. And with primary care, where we are right now, it's incredibly fragmented, universal owner, collective health. Because we all benefit. Everyone's seen that we benefit from a strong primary care. The way we're looking at it is as a public infrastructure, not, you get lucky if you got the right parents, you get insurance. It doesn't work like that. So the big part that's really important to see in this is that right now, as a chief medical officer, my community health center, basically, I pay 6% of my revenue to some accounting firm somewhere to push all our papers through billing and fight the insurance company. Like their AI fights the insurance company's AI. So 6% of my revenue, that's my margin. We have so many different payers. The idea that we're looking to do is multi-payer, single fund. And that common fund then provides per member per month prospective payment to clinics. So they can do the team care, so they can do the asynchronous care. They can get off that fee-for-service nightmare. And you have to see, the infrastructure that we have for the status quo is expensive. It's expensive for the insurance companies, it's very expensive for my clinic. I just want to send a bill, one place, and I get back 6% of my revenue so that I can invest in nurses, community health workers. These are the kinds of things that can be very helpful. And the idea behind it is we don't need to add one more penny if we do it this way. The money, just putting the money in the right path and using it as a universal resource as opposed to fighting over every fee-for-service visit. So, mutual benefit, where we are now, where we go, you guys get the side story. So using it as a universal utility is what's going to allow us, rising tide lifting all boats, meaning I get to have, and this is the other thing, the equity on this is huge. Right now, MGB gets paid twice as much for a visit that I do in our clinic. And trust me, we need the money more than MGB. That may be true. So, the system aligns for the patients, for the insurers, for the providers. It is a common health, the common fund for the Commonwealth. We can do this without adding one more dollar into the system. And the best part about this is, we have, where's Fitzsimmons? There you go. You gave me a leverage the latent capacity. In this state, we have sufficient primary care numbers. We do. It's just no one's working full-time because it is a grind and it's a nightmare. This will allow us to bring that latent capacity to fruition instantly. We could probably increase our capacity of 20% if everyone was able to go into team care and didn't have to do pajama time. Most of my providers were 0.3 patient-facing. I know that if we could get them the right supports, they would go up to 0.5. The latent capacity is there. It's how we pay for it that counts. We have a chance to change, and we're going to talk about it.
We'll trade seats. Good afternoon, everyone. Thank you so much for the opportunity to moderate this panel. I'm Corey King. I'm the Health Insurance Commissioner in Rhode Island. I want to credit the authors of the paper that was published today for writing such a digestible and I think morally impactful piece. It's going to lead to a lot of good discussion, and thank you, Renee, for that excellent overview. It's good framing for some of the technical questions around feasibility and practicability that I have. I want to take just a moment to make an observation about primary care, and then that will lead to our first question. So in 2021, the National Academies of Sciences, Engineering, and Medicine published a report on primary care. If you look at page 3, after a definition of high-quality primary care, the authors state, absent access to high-quality primary care, minor health problems can spiral into chronic disease, care management becomes difficult and uncoordinated. Visits to emergency departments increase, preventive care lags, and the nation's healthcare spending soars to unsustainable levels. It's a lot of really bad stuff. So if that's the case, if access to high-quality primary care allows us to obviously avoid all of those really bad things, then Dr. Altman, why don't we fund it appropriately? And speaking to scarcity of payment, we only have one microphone, so.
I mean, I can just project. Can you hear me okay? Yeah. Use the damn mic, okay. My bad. All right, well, a few thoughts, Corey. Number one, we recognize we're in the middle of the afternoon after a reasonably high-carb lunch, so we're going to do our best to keep you awake in this conversation. Number two, thank you for crediting the authors to that paper that was in JAMA today. I want to also credit, in addition to the three of us, Zuri, myself, and Renee, Dr. Kevin Grumbach out at UCSF, who wanted to be here today but was not able, was our fourth author and an important thought leader in that area. Well, I'm going to answer your question now, finally, and kind of reference a concept that Michael Fine taught me a long time ago, which is our healthcare system is based predominantly on one overarching concept, which is profit. Profit is what determines the system that we have today and why things are the way they are. It might have been Don Berwick, or maybe he was quoting someone who said that every system yields the results it was designed to yield. Is that Don's quote? Or
That's Don's.
yeah, and we are getting the exact results our system is supposed to yield when it's based on profit. And we've had a lot of consensus today. Senator Friedman said, why do we even need to talk about why primary care is good? We all know primary care is good and what it does. And so the consensus is there. Primary care is good. It can save money. It can generates better health and more health equity. We've got the consensus, but we've got the wrong force in our system. And the only way to change that force of profit is through legislation. Except there's a problem. If we put legislation forward today that designs the perfect primary care payment model, which there is no such thing, but let's hypothetically say we've come up with the perfect model, it cannot apply to self-funded plans, which is 60% of our commercial market. And that's a major problem. Some of you know John McDonough, who's a health policy icon in this state. And I met with him 7.5 years ago when we started talking about this in Massachusetts. And he said, these are all great ideas, Wayne, except you're going to run into ERISA like a brick wall, and you won't be able to get past it. Okay? And then one day, I'm going to say about 3 years ago, Zuri and I were talking, and Zuri came up with this idea of a primary care stabilization fund, or as we prefer, the way Renee calls it, the common fund. And we believe that concept of establishing a single payer or a single administrator for primary care bypasses ERISA. And Liz McCuskey is in the audience. Where are you, Liz? There she is. Yeah, we'll agree. And she...
From Rhode Island.
From Rhode Island. And NBU. And she and her colleague, Erin Fusey Brown, actually studied this in great detail and wrote up a 10, 12-page memo describing how what we're talking about here with this common fund would be ERISA compliant and would apply to the entire commercial population, not just 40% of the commercial population fully funded. I've spoken too much. Back to you, Corey.
Thank you so much. So when I read the paper, a few words stuck out to me. Public utility, which conveys regulation, maybe lots of regulation. So I'm wondering, how can you make this concept of primary care as a public utility palatable for red states or for policymakers on the right end of the political spectrum? So I'm going to ask Zuri to answer that question.
Thank you, Corey. It's an honor to be here with all of you. Thank you for having us. The motivation for this piece actually arose from listening to many state policymakers across the country for many years describe the need for bold fundamental change to support primary care. Many of our leaders, elected leaders, policymakers have specifically mentioned that the more incremental types of approaches that we've seen for decades haven't really changed the paradigm for the primary care reality. And so, we've studied those from the academic community, adding new codes to the fee schedule. I'm a big supporter of Corey's state as a leader in investing in primary care as a percent of healthcare spending more and more each year. And the policymakers I was listening to from many states, partly through my work with NASHP, our colleagues there, seemed to suggest they were looking for something different. And so there was a time when you'd sit back and think, what is it that they're motivating? What is bold, fundamental, and not the same as what we've tried for decades? As you know, our new codes in the fee schedule generally aren't used or billed by practices much, leaving a lot of dollars on the table. So the idea behind this paper really was to formulate a potential answer for them to consider. It's the broad outline of an idea that might fit their boldness and fundamentalness as they've been motivating all of these years. And to Corey's question, it essentially solves two problems which can be applicable to multiple states. So the first problem is the state authority restrictions. Most states, as you know, can touch their Medicaid lives, fully insured lives, including state employees and the uninsured. But they cannot really touch self-insured, commercial, or Medicare. If you add them together, it's usually more than 50% of the state population. So to deliver subsidies or help to primary care practices directly, you have to get out of the state authority box, essentially. The second related problem is the market power issue and the payer mix issue. So if you stipulate that in any given state, you want primary care spending to go up by 1% per year more, the actual amount of 1% is different depending on your payer mix. If you have a lot of commercial patients, that's actually more dollars. If you have more Medicaid patients, that's actually fewer dollars. So on a per capita basis, it's actually quite different, the amount of subsidy you're delivering out into the community. And so you would need a mechanism that steps out of the fee schedule, because the typical way these subsidies work is within the fee schedule, within the negotiated contract between payers and providers. Well, how do you step out of the fee schedule practically? You'd have to have the funds sit in a separate pot, which is then directly dispersed to practices. That separate pot it really cannot be the fee schedule. So it turns out that if you step outside the fee schedule, you solve both of these problems. You can now decide how much primary care subsidies per life, per head, per person, as opposed to per one type of insurance versus another, versus no insurance. And you can sidestep the state authority constraints, potentially with a waiver for Medicare, and there would need to be more work. But the basic idea is stepping out of the fee schedule allows you to help everybody, and it allows you to get out of the bind of different prices for different people based on market power and payer mix. Having solved both of these problems conceptually, then it comes down to how do you appeal to different states. And again, this paper really was a response by the state policymakers' push for something bold and fundamental. And so the way it answers that question is, it has several pillars that could potentially appeal to our traditional way of thinking about this from a right-of-center mechanism or left-of-center mechanism. So the paper describes why this kind of common fund, where multiple purchasers, multiple payers, types of payers, finance a common pool. The common pool then pays out directly to primary care practices. And this change in the mechanism does not require new money at first. The structural change in the payment mechanism does not require new money, like Renee said. What could appeal to, let's say, folks who value the right-of-center principles? Patient freedom is one. Now, patients are tied to the practices, not to a certain type of insurance with a certain network and certain practices in the network. If you decide to leave your job and go to a different job, you can still keep your primary care at the same place, because the subsidy for you is just going straight to the practice. It's not tied to the insurance. If you decide to purchase primary care, where's my DPC colleague, from a more free market DPC type practice off of the insurance context, you can do that. If you decide to forego primary care because you don't have to eat your broccoli, as we learned through the ACA debate, you can do that. There's no mandate or forcing mechanism here. It's complete patient freedom and patient choice. The second pillar for the right-of-center way of thinking about this is state choice. This is really a state set of options. States can take this and pay primary care fee for service. They can pay with an alternative payment model like Renee talked about. It can add financial risk to the providers, or it can recognize that primary care doesn't really control the other 95% of healthcare spending and forego that financial risk. It can still add in some shared savings, some quality bonuses. It can do all of that based on what it cares about, and it can adjust the payments for social determinants of health that basically reduce incentives for upcoding while getting subsidies out to the more disadvantaged communities. So it's a whole set of state choices that the federal government is not mandating. There's no single payer mechanism mandating. So that's the second one. The third one is essentially administrative burden reduction. We've seen through multiple conservative administrations that at the federal level, that is a really big priority. Well, it just so happens that one of the things that really reduces your administrative burden is not having to deal, from a primary care practice standpoint, with 20 different payers. You just have one common fund dispersing to you, but it's going to hold you accountable for that primary care spending. You might have to report some things, like how you use the money, the continuity of your practice, how many patients you serve, maybe even how much you paid your doctors. But it's just one source. It's not 20 different forms and different systems anymore. There's nothing that directly more reduces practice burden than going from multiple payers in a fragmented, pluralistic system down to one. But if you then ask, okay, well, we've achieved those pillars of the right of center preferences, what about, is this just a slippery slope to single payer? We've made it very clear in the paper, primary care is 5% of healthcare spending. You can do a common fund like this for 5% of spending and leave the other 95% untouched. The other 95% of healthcare spending, all the specialty, post-acute, hospital, drugs, and everything else, is status quo in this way of thinking about it. They're undisrupted, unperturbed, and so this should be quite less threatening or disruptive for those who believe this is really something dressed up as single payer. In fact, this is multi-payer financed, one common fund dispersed. It's actually quite a mirror image of one of the favorite mechanisms of our conservative colleagues, which is the Medicare Advantage program. The Medicare Advantage program is a common fund at CMS that basically is multi-payer, I mean, it's taxpayer financed, multi-payer delivered. And we explain in the paper, this is why it's a mirror image. This is multi-payer financed, one mechanism delivered. And at the same time, it's got the patient freedom and the state choice. But if you're a left of center thinker and you have different social preferences, well, this achieves the universality and the equity and the guarantee of access that is really important for all of us who believe healthcare is a human right, that at least primary care, you should have some guarantee of access to primary care, even if your insurance plan or employer changes in the tiered networks for the hospitals and the post-acute and your drug benefits, even if those things have to change because we live in the system we have, at least for primary care, you can get to closer to the vision that you perhaps would prefer. And so that's the way that we see this as a potential political compromise. And we talk about the political compromise in the paper a lot and some precedents for implementation.
Thank you, Zuri. I do want to put in a plug to the audience. I'm not going to monopolize the questions, so be thinking about them. I have one question for a panelist, and then I'm going to go to the audience after that. So partisanship makes me think of how you build a case for political change. And Zai, you recently led an effort to preserve the birthing center at Newport Hospital in Rhode Island, keeping that critical piece of healthcare infrastructure in place. So I'm wondering what lessons you learned from creating that coalition that could be applied to the case of supporting primary care more broadly, which is in all communities.
So you can't make this stuff up. I have my college 20-year reunion coming up this weekend. And I go to sit down and I see my RA from my freshman year. What's up, dude? And we're talking and he says, hey man, what are you up to these days? I said, well, you know, for a while I worked in investment banking, working with public utilities, large water utilities, that type of thing. Peak of Occupy Wall Street, turns out people really don't like bankers all that much. So I figured I'd go to law school, right? Become an attorney because people really like attorneys. That can work out. And I'm really lucky that Dr. Fitzsimmons laid the groundwork for politicians on today's remarks. And so you dove into the realm of politics for the same reason I think most of us do that run for elected office, which is you see a problem and you want to make things better. The best policy arguments in the world don't matter much if you want a priority for elected officials. So how do you become a priority, right? I can tell you, having knocked on lots of doors, crisscrossing the state every day, in the statewide race I'm running for right now, people very rarely list healthcare as they see something that immediately they expect their local elected officials to deal with. This is important because right now people's faith in government is at an all-time low. So government really needs a win right now. It's a hard case for us to say that we're going to be able to tackle an issue as complicated as healthcare. When you drive down the street and you probably curse out elected officials every day saying these guys can't fix the potholes. Now you're going to trust them with a system? And so what you need to do is you need to do two things. One, you need to find an inflection point that happens in your community. I remember the first time I realized there's a problem in the healthcare industry, I was about 7 years old. I was tagging along with my mom as she did her weekend rounds at the hospital. And we were in an elevator to go up, and a bunch of hospital executives got in. They said, we're sorry, we need this elevator to get up to a meeting. So we got out. And I'm sitting there as a kid, and I was like, well, my mom is not only the most important person in the world, but she wears this white coat. She's super important in every environment I go to. And who are these people in suits that just bounced her out? So that was a red flag for me. Fast forward, right, 35 years later, my wife loses her primary care physician, and she can't find anyone for a year. Turns out that it doesn't matter if you're the first lady of America's most iconic city, that your mother was a pediatrician pretty prominently locally. The math is the math. When you're in a state like ours that's 300 physicians short, with 1 in 4 set to retire in the next 5 years, you can't cut around that. It's, I think, at some point your communities are going to face an inflection point like we faced in Newport, where the large healthcare network looked at the profit margins, and they said, this women's health center, this labor and delivery unit, not where the profit is. And so, if women need to drive an hour to deliver a baby, that's not our concern. We have to make our bottom line work for the overall pressures that we have. So you're going to have that inflection point. And it's going to come in this community where all of a sudden, it's not a one-off individual story, it's a community-wide story that people can relate to. The second thing you need to do is actually have a channel to act through. We're very lucky in our community that the chairs of our House and Senate Finance Commissions were there. A quick show of hands here. How many of you know who your state representative is? Not your congressperson, your state representative. Now keep your hands up. How many of you have donated to them? Or knocked on doors for them? You want to know why we have such good fire service in this country? Those guys show up every single time. And so our ability to have impact on this very small issue cracks the door on why people need to be involved in primary care. But for us having avenues and contacts with our state legislators, that would have been possible. If there's one word of advice that I have to give to you, it's to go to my website. I'm just kidding. It is to get involved with whoever your state legislator is. Because the federal government isn't going to ride in to save the day. They've largely said this is a federalist system, and that's why this paper is so good, because it takes a federalist approach to solving this problem. You need to know who your local legislators are. You need to be involved with them. You need to make sure that they know who you are. Because you are among the most respected members of your communities. I know that when I go out places with my mother, more people recognize her than recognize me. That's the impact you have on people's lives. And it's across all classes. You're some of the few professionals that have that level of diversity in your reach. And so your legislator will know exactly who you are. You need to know who they are. Show that you understand their business and make sure they make this a priority. So thanks for the question, Corey.
Was there a question in the front here? Did you have a question?
I had thought to myself, as Dr. Help me, song was speaking, that a common fund or a mechanism like that, sure, I see it as a recently retired primary care doc as relieving administrative burden and a nice opportunity for streamlined billing, only dealing with billing and payment, not only dealing with one entity. But do the participating or the local insurers for self-insured folks via employer, in order to be part of the common fund, is there an opportunity to say to them, look, if you're going to take care of people in our region, we're just not putting up with as much by way of deductible, copay, prior authorization.
Yep.
Is there a leverage point there that could be utilized? And have any of the common funds that we know of been doing that?
Thank you very much. Thank you for that question, sir. When the self-insured commercial lives have a way of joining the common fund, which is a challenge, I just want to be really transparent and concede that still remains a policy challenge, especially in states where either employers may not want to join or states would have to use a different authority to get them into the common fund, such as taxation. States can assess taxes on employers. So this could be a way for employers to join. You would get to a point where, upon contributing to primary care in the common fund, you as a self-insured employer would no longer have a reason to buy primary care twice in your traditional insurance plan. You could if you wanted to. You could double pay for primary care if you wanted to. But you wouldn't really have a reason to. So the economic rational decision would be, all right, I'm already paying for primary care through my state's common fund. Now my regular insurance plan will just cover the other 95% of healthcare spending. So premiums should be a little bit lower, the network, the tiering could be a little bit different. You can see how that has spillover or downstream consequences for the other 95% of spending, which still lives under insurance. And by the way, even for, we've sometimes called this the direct primary care model for all kind of thing, more universal direct primary care model. Even in a DPC model, it is often the case that patients carry health insurance for the non-primary care portion of spending. This is very analogous to that. And so we'd expect from a natural market evolution and competition standpoint, if there is competition in the insurance market, that the insurance plan's benefit design should evolve to essentially allow primary care to carve itself out. Now, Corey will have other really compelling, potentially concerns about this or thoughts about this, where a state government would need to be able to manage the common fund well. That's not a given, it's not a guarantee. But again, it is a way to meet the policymakers' own stated objectives of something different, more bold, more fundamental. You know, and I guess another good question is, we don't have to actually support this idea. This is, you know, papers come and go, they often don't make a difference. But one interesting question would be, if not a bolder, more fundamental change like this, what other bolder, more fundamental changes can we envision that would achieve what policymakers have been asking for? I'm genuinely, you know, curious about that.
Just to add a little bit to that, I will tell you this. I definitely believe what I've seen, and the data is bearing it out. People are going to much more high deductibles. Something like, they're saying that most of the, especially younger patients, are getting high deductible plans, anywhere from $2,000 to $5,000 deductibles. And I imagine that employers have no problem with that because they're generally cheaper. But the thing is, what that does for primary care clinics is, honestly, it can cut us out because people they won't meet their deductible by coming to see me. And so the folks that we do have that come and they're still within their deductible, our commercial insurance actually loses us like $200 a visit because they're in the deductible and the patient doesn't pay. And we have to see all comers. So what I will say is, I do think that what's going to drive the self-insured employers is it's a better deal. I honestly think that John Hurst is the Small Business Association represented on our primary care task force. And what I hear from them is, we want lower costs now. And the fact is, they would benefit from this having to be the path that primary care is paid. It just makes better sense. I think the employers are actually going to be the ones that are on our side. We might get sued, but I think most of them will see that this actually pays better.
So I want to touch on a paragraph that is included in the paper. Because, look, I sit in state government. I've been in state government for over a decade. I have a concern about government failure, right? So the inability to regulate a particular market or public good. So page 4 of the paper says, I'm just going to read from it, public programs can be vulnerable to fiscal pressures. Carving out primary care into a common fund may subject it to cuts. To guard against this, states could include a statutory requirement to finance the common fund with a budget index to an explicitly defined primary care investment goal, similar to investment benchmarks already adopted in multiple states. Wayne, what if that doesn't happen?
It will.
That's why.
So, the first thing that got legislated around this legislation was a year or so ago when Massachusetts legislated the establishment of a primary care task force. Renee and I are 2 of the 25 members of that Massachusetts primary care task force. And one of the first things we talked about was this issue. And with with ease and haste, The 25-member task force that included insurance companies and hospitals and broad stakeholders agreed on moving towards both a doubling of primary care investment in Massachusetts and bringing it to 15%, whichever is higher. The concern was raised that other states have legislated that you had to get to 12%, but then to find their way to 12% without actually putting significant increased money into primary care. So then they said, fine, we'll double it or 15%, whichever is higher. And there was consensus on this. And I do believe, as I said earlier today, that this year we will pass historic primary care legislation in Massachusetts that includes that provision. But we have to keep fighting for it and not take that for granted.
So I think there was a question here in the front.
Yeah. Well, I'm just teeing off of what you said. I'm not from Rhode Island, I'm from Texas. And it's been novel to watch primary care, which in Rhode Island had made such great progress, dismantled by a misguided and ignorant Blue Cross Blue Shield leader, and watch the impotence of the state in stopping that. And we've watched RIPIC, we've watched primary care groups go bankrupt, and you all are supposed to be the leaders. So how do we combine this legislation with what we're watching happen in Rhode Island, which is basically a defunding of primary care systems to actually take care of the people of Rhode Island?
Not fair to ask questions of the moderator.
So I think that's a question for me. So I'll tell you a brief story. So back in early 2023, I had become the acting health insurance commissioner the December prior. And I was reading an article in the newspaper about limited access to primary care. I forget whether it was in the Globe or in the Projo. And they reported a retired physician who couldn't find a provider, couldn't find a primary care provider. If you're a physician, you are the ultimate insider. And if you can't find a provider, then God help the rest of the population. So we undertook a strategic reevaluation of OHIC, Office of the Health Insurance Commissioner policy. Was the regulation working well? Had we defined primary care in a way that limited insurance companies from gaming the definition? And we found that there was an opportunity for us to revise the regulation by effectively changing the denominator. We have a ratio-based target. How you define your ratio really matters, right? How you define the numerator, but the denominator really matters. The denominator during the previous commissioner's regulations only brought in Rhode Island provider payments. There's $200 million of out-of-state payments, mostly in Boston, that Rhode Island residents incur that weren't in that denominator. So I brought them in. And rebased, we went from 10% back down to 6%. And before the regulation was enacted, we went down to 5% and to 4%. But the regulation requires now that by 2028, insurance companies in the commercial market dedicate at least 10% of total medical spending to primary care. In 2025 and 2026, the insurance companies had to begin implementing that through increased reimbursements, through increased capitation payments. During last year's rate review process, when insurance companies were asking for 20% rate hikes, I approved significant rate hikes, including a 3 to 4% increase, just to fund that primary care increase. And Blue Cross Blue Shield, it's not my position to defend anyone's particular strategy. I think that there has been a devolution of the relationship. Blue Cross Blue Shield since July of 2025 has increased its reimbursement for primary care by 30% on its fully insured book of business. Not on self-insured, which we spoke to that earlier. And they asked self-insured groups to opt into this enriched fee schedule. They all said no, including the hospital systems, which are some of the biggest employers in the state. No, we don't want to invest more in primary care. The only self-insured employer in the state of Rhode Island that I'm aware of investing more in primary care as an employer is Blue Cross Blue Shield of Rhode Island. Hopefully that answers your question. We've got a long way to go, and happy to touch base with you after on some of the next steps we have in Rhode Island. I do want to kind of get back to some of the discussion. We talk about the common fund as a response to the administrative burden that providers are bearing. So when I talk to primary care providers, I hear complaints about the burden of prior authorizations, coordinating referrals, working with EMRs, the pajama time that Renee discussed. How would the Common Fund alleviate these stressors? So maybe I'll go to Renee.
I love this. This is good.
All the cool kids wear the striped hats. So this is the thing. Fee for service is all about visits. I love my CFO. Love my CFO. Love my CFO. All she wants is more and more visits. More and more visits. More and more visits. And as we heard earlier, the data demonstrate that for every hour of patient-facing time, you generate 2 hours worth of work based on your panel. So, and where do we give people the time to do this work? They're running around in between patients. That's why they're late, 20 minutes to your visit. And then they take it all home. The fact is, we have a lot of people that come in that we actually could reach out to. We have a lot of people whose care would be done better for that particular issue by not a physician. But my clinic only gets paid if you come and sit face to face with one of our clinicians. Except now in Massachusetts, we have the 1115 waiver, which is a per member per month prospective payment. And we have 45% of our patients in capitation now because of Medicaid. Because of that, I was able to go to the CFO. You have to bring them coffee, it's good. And I said, listen, our panel size is this, and it hasn't increased in 6 years. That's our panel size. Hasn't increased in 6 years. We have a per member per month that brings us, honestly now, millions of dollars prospectively. I said, I have a couple of providers based on their panel that are pulling $1.4 million of revenue. Let's support our providers so that we can increase patient access. And they're like, what do you mean support? We're not giving them more money. I'm like, they don't want, well, they do want more money. But what they want more than anything is time and space and support. So we have done a complete remodel of our clinical design, put a lot of clinical support and administrative support around our providers, and the first 2 visits of the morning is just supported embedded administrative time, and the first 2 visits of the afternoon is supported embedded administrative time. It's office hours for the clinicians. I would not be able to do that if we did not have 45% of our patients in capitation. We also have an AI scribe, which I had to fight for that. The way I fought for that was I showed them the open encounters that we weren't getting paid for. I showed them the people that were cutting back every year on the number of hours they were doing patient visits. The AI scribe and our team-based clinical care time has decreased pajama time from, I have some folks that were 4 hours a night. They make their notes too long. But most of my folks are less than an hour now, and we think that we can actually get it lowered. Inbox support is now with MAs, we have unit coordinators, nursing is on the team, we have team care, we have time and space to do that care in a supported, embedded way, and we can only do that because of capitation. And I will tell you this, that's the kind of stuff that's going to unearth this latent, leverage our latent capacity that we have there. The biggest thing I'm going to see if we do this common fund is more independent practice. More people who are not working for the big MGB and the big DI. People rolling out of residency and saying, hey, we like each other, let's start a clinic. Because it'll be simplified, the administrative burden is gone, and they can fund it themselves.
Yes.
Very good.
So, Zuri mentioned earlier that this is kind of a DPC for all kind of model, and Sarah gave us a great talk earlier this morning on direct primary care. And whenever you listen to a talk about direct primary care, you finish, you look at all the data, you think about it and you go, damn, this makes so much sense. It makes too much sense. And really that's what Renee was just talking about, is direct primary care. But what's interesting is that when you think about direct primary care and how much sense it makes, then you ask yourself the question, how do we scale this? We can't do it the one doctor at a time kind of scaling that where we are right now, pace-wise. It will be ready by 2090, okay? And so, and in the meantime, every doctor that goes to direct primary care, because it makes so much damn sense, reduces their panel from 2,000 patients to 400 patients. And I don't begrudge the folks who do it. I have great respect for folks who choose direct primary care, but it does worsen the access issue with regard to primary care. So what we're talking about here with a single payer for primary care with a common fund is an ability to scale DPC in a way that doctors don't need to leave their practice or reduce their panel size to scale DPC.
So I'm going to ask for short responses to these next few questions, because I also want to mix in another audience question if we can get that. Yep, so we'll try as much lightning here. So we talk about a prospective payment from a common fund. Policymakers have an interest in tracking utilization metrics. So would practices still need to generate claims and file shadow claims? Maybe Zuri, you can answer that.
Thanks, Corey. I think record keeping remains important on some fundamental level to know what you did, to know how many visits you administered, but it would not have to have all of the billing and revenue cycle management stipulations attached to it. I think record keeping is just still important fundamentally.
And I had one more technical question I wanted to ask. For the last 15 years, we've been doing value-based payment largely through an accountable care organization structure. Patient attribution has been a thorny issue. So how does patient attribution work itself out in the common fund model? And I'll ask Zuri or Wayne to weigh in on that. Unless, Renee, you want to talk about patient attribution?
Sorry to speak twice in a row. Yes, my colleagues and I have studied ACOs for many years, and attribution really is challenging. Here, patients vote with their feet. The attribution is the practice in which a patient has chosen their primary care provider. And again, if the patient wants to make a different choice or leave or change, they can do that at any time. There's no signing up period in terms of the enrollment, in terms of the annual enrollment for insurance that's going to constrain this. There's a version of the common fund which, dating back a few years, I'll just very briefly say, there's a mechanism for this where you can just allow the patient to provide this annually, let's say, on their state tax forms. Right now, we all, in filing our taxes, have to indicate, I think because of the Affordable Care Act, do we have health insurance coverage? Each of the 12 months, there are 12 boxes right, on that form. Imagine instead of just saying yes or no for the 12 months, you just indicate where your primary care provider is for those 12 months. And that would be your attribution. You just vote with your own feet, and then we have a natural mechanism for keeping track of that.
Renee has endorsed that.
Yeah, that's good.
All right, so Zuri will not get the next question. Maybe I'll direct this one to Wayne. For nearly 40 years or longer, Maryland has had a all-payer rate-setting system for hospital services that relies on the existing chassis of insurance-based care. So, Wayne, why not just go for all-payer rate setting for primary care? Why do the common fund public utility? If you can respond to that quickly.
Were you going to say something? I'm not sure I entirely understand what you're distinguishing.
Yeah, so you're taking primary care funding out of the insurance company
Yes.
and distributing it out through the state, whereas an all-payer rate setting system, government would establish what the reimbursement rates are, but the underlying payers, commercials, Medicare, Medicaid, would continue to pay the bill.
Insurance doesn't belong with primary care, period, end of story, okay? Insurance is for catastrophic and unexpected outcomes in every insurance industry. Primary care events are not insurable events. They're not unexpected, they're not catastrophic. They've had a chance for 40 years to fix healthcare and to fix primary care and make this work. They have failed. It gets worse and worse. It gets more expensive, less accessible, and we're getting less healthy. It's not working with insurance in primary care.
Louder!
Insurance needs not to be part of primary care.
Yeah, you're welcome.
Be out of healthcare.
All right, so I think we have a question out here in the audience, so if someone can pass the microphone. Okay, we'll do these two questions here then, back here.
Thank you so much. I'm a primary care doctor in Cambridge. I coordinate.
Good to see you.
I'm a family doctor who does obstetrics in Cambridge, Massachusetts. I'm at CHA if anybody wants to come to me, Windsor Street Clinic. And I coordinate the Massachusetts State Work Group, and I'm trying to get one started in Cambridge as well. I'm curious what your perspectives are on making primary care, like the responsibility felt heavily by politicians at the local and state levels. Is that a public meeting strategy where we feed everyone? Do we canvass? How does this sort of politics and priority setting work?
I finally got a question.
We're at a critical breaking point, right? And people feel there will be something that happens in your community. Maybe it's not the closing of the birthing center, maybe it's the folding of a major practice that has a lot of people going to it. That's an inflection point where we're talking 100+ people are going to be left in a lurch overnight. And the key is to organize those people as quickly as possible, to get their contact information and to press them to drive in actually reaching out and contacting their legislators. You're going to recognize Cassie Ball a little bit later today. Cassie was a mother in our community, had no political background or training, and we rapidly got her organized to lead that outreach. And so the face that's at the forefront matters, and doctors have a really important role to play here. In all the years that I saw my mom care deeply about her patients, I never once saw her actually engage politically until later in life. This is where you can tap retired doctors incredibly effectively to get out there and get active. I can guarantee you they're out there no kings marching, right? We need them doing that direct outreach to their state legislators and doing and organizing that work. That's the most effective way to get out there. And show up. Show up when they do events. You don't have to donate, you just have to be there and to have them see you, and we will value your presence being active.
I would also note one other thing too, which is that with all these things, right?
We know what needs to be done. This isn't complicated. We know that we need to raise the reimbursement rates that primary care receives. We know that we need to make this a more attractive profession. It's focused on why you got involved, which is delivering patient care and not filling out billing codes. And so if we know that, when we have solutions like that, we've got to press on that common sense. And if lawmakers can get with it enough to understand ERISA, I can't believe you brought that up during the coma hour, right? Then they can understand the basics of the fact that doctors want to practice medicine and treat patients and take care of people, not be hunkered down dealing with billing codes and paperwork, and they want to be compensated for their work. That's basic. We can understand that at the most basic level, and I would say you should keep pressing those points.
So you believe that ERISA is an evidence-based treatment for insomnia?
So I want to do one more question. Was there a question over here? Okay.
Corey, she's had her hand up for a while.
Okay, I'm not really getting a good look at the room, but sure, we'll go over here.
Sorry about this.
Sorry.
I was just doing that.
Hi, I just wanted to first give a quick congratulations to the Newport Birthing Center. Sorry, I don't know the name. And then where has the research been to take a look at how this will address Black people specifically, to make sure that they are a part of and not a part of as in rising tides lifting all boats? And okay.
Who wants to take that?
I'm sorry, one other thing. My mom, for very many years, went to Cardigan Square Health Center, and I really do appreciate you. And tell Dr. Mullica I say hello.
See, there's continuity.
Continuity.
Yeah, you got it.
She was not playing with Dr. Mullica.
So this is the best part about this is that You don't even have to use the word equity. You can just use the word evidence.
Okay.
The evidence is that you put more primary care physicians into a community, that community gets healthier. It is literally the only specialties that you can put in a community and that community gets better. This will help marginalized communities even more than, sorry, white people. And the way it helps more is this. It's not that it decreases access for other folks. It increases access, and I, as a clinician in Codman Square, seeing the same person with the same issues will get paid less than I would if I worked for MGD. My clinic, we see 110,000 visits a year. Every one of those visits, if they went to MGD, MGD would make twice as much money. So this is the kind of stuff that is a grand equalizer in the financing and revenue part. And I can start paying my clinicians as much as MGD pays their clinicians. And that means more folks in Codman Square being seen, increasing patient access. Lightning.
My friend Renee taught me a long time ago that equity is allocating resources to where they are needed the most. There is no more powerful lever to do that than increasing investment in primary care.
Amen. So, I've been informed that we are out of time.
No, let's keep going. This is too much fun.
If we have extra time, we can keep going, but I believe we have to move on. I imagine the panelists will be able to take questions after, if you're interested. But again, join me in thanking all the panelists.
All right, thank you very much to the panel. One more round of applause. So we are about to take a 10-minute break, but before we do, let me invite Dr. Ashtari up to talk about what we're going to do when we come back from the break, promptly at 3:15. We will talk about, do our table talk. Go ahead.
Okay, everyone, we're really excited about this next part of the summit.